right, welcome to Conversations on MS. We're here tonight to talk about MS with Dr. Anna Shah. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb and Genentech. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. If you enjoy the format of tonight's program, we have one more session coming up in October with Dr. Enrique Alvarez. I really enjoy seeing multiple doctors explaining things in different ways, so we hope you'll tune in to the whole series. We also have a webinar coming up with Dr. Andrew Wolf on the use and misuse of stem cells in MS. That will be October 17th. And our Fall Education Summit will take place on Zoom and at Anschutz on November 16th. Topics covered at the summit will include research updates, the possibilities of CAR-T therapy, aging with MS, and managing invisible symptoms. We announce all of these opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. And now I'd like to introduce you to Dr. Anna Shah. Dr. Shah was born and raised in Chicago, Illinois. She attended the University of Missouri, Kansas City for both undergrad and medical school. She went on to complete her neurology residency at the University of Michigan, where she served as chief resident in her final year. She completed her fellowship in MS and neuroimmunology at the University of Colorado. She sees patients with MS and other related disorders of the nervous system and has a special interest in women's health and family planning. We have a lot of questions submitted, so just a reminder, we'll get to as many of them as we can tonight. And today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. With that, I'll turn it over to Dr. Shah.
Perfect. Well, thank you, Kelsey. And I'll put in a plug. I think Dr. Wolf and Dr. Alvarez are great speakers, so try to attend those if you can. I'm just going to go down the list of questions that were submitted before today's webinar. And then, like Kelsey said, submit questions as they come up, or if other questions come up spawning from the questions that I'm answering. So the first question that I have here is, would you recommend patients obtain advisement from functional medicine providers as well? It seems like my doctor tries to solve all of my problems by prescribing more medications. And that one probably is a little bit specific related to the type of medication. I will say, I think we work really well in MS care when we work holistically, meaning we have a functional care team. And so that involves the neurologist, that involves primary care doctors, that involves other subspecialists, whether that's psychiatrists for mental health, urologists for bladder health, GI doctors for GI health, or kind of thinking about physical therapists, occupational therapists. I mean, that list goes on in terms of how big a care team can be in MS. And so what I would actually suggest, and I would say, if you haven't seen, I think there is quite a few symptom management webinars or resources through the MS Center that perhaps Kelsey can throw in the chat. Those are really good ways to look at, because I think for almost every single MS symptom, there's a non-medicine and a medicine way to approach it. And I think it might also be worthwhile communicating with your doctor. Well, I appreciate the medicines, but is there a non-medication way to approach it? I think there are some really great functional medicine doctors. I think the caution I have sometimes with them is sometimes some of the supplements that are prescribed by functional medicine doctors, some of them ramp up the immune system, which is the exact opposite of kind of what we want to do in MS. And so it's just important to make sure that we're not taking something that's counteracting kind of what our treatment goals would be in MS. The next question I have is, do I know if Sativex or the nabiximols have been approved in this country? If not, do you foresee it in the future at all? Which is a really great question. I might give everybody a little bit of perspective on that for those that are not familiar. So the nabiximols and Sativex in particular was a spray that had a combination of THC and CBD. It was originally being studied 4-ish years ago, looking at its use in spasticity. I actually did hear something a couple weeks ago that the company that makes Sativex might relaunch a trial. Now, I think a lot of that is conversations rather than an actual date, but I do foresee it hopefully coming up in the future, maybe in the next year or so. I think what the biggest change they'll probably do is a little bit with study design. We know study design is something that helps contribute to the success or failure of a lot of medications. And so I think that is something they're looking at. So that's kind of the very early stages of what I've heard with the nabiximols. The next question, can MS make you gassy or cause burping? It shouldn't in general. Now, MS can affect your GI system. Sometimes it can contribute to something we call gastroparesis, which is slowing down of kind of the GI motility. And so, for example, if you've got a lot of slowing down of GI motility, could that secondarily make you feel more gassy? Possibly. Usually what it leads to is maybe more nausea or feeling full faster, rather than necessarily gassy. But I think the other thing, and this will tie in really nicely to another question, which is what are best diet recommendations in MS, is just because you have MS doesn't make you impermeable to other things. And so is it possible that there's a food intolerance to something you're eating that's contribute to the gassiness or increased risk of burping? Speaking about diet, there is not one magical diet for MS. The things that we know about diet studies is they are hard to do well. And in a lot of the diet studies, when you're comparing diet to overall MS outcomes, it becomes really challenging to say diet itself affects MS outcomes. But we do know that overall diet has a huge role to play in the health of someone, and in overall brain health and heart health. So I'll take a quick side note. In MS, we know that if you have other comorbidities, those are things like high blood pressure, high cholesterol, diabetes, all of those things help accelerate how fast your MS progresses. So you can imagine doing things like eating reduced sodium, especially if your blood pressure borders on high, or having a lower carb diet, especially if you've got a strong family history of diabetes or high sugars. Doing things like that is going to have a secondary benefit on your MS, although it's not necessarily, I eat this, my MS gets better. The diet that has, I think that all of us here recommend, that's been shown to have the best data for overall brain health, is the Mediterranean-based diet. But we often say eat a little bit with common sense. And I think one of the biggest pitfalls that I see with diet is people saying, well, I'm sticking entirely to this diet, but if I'm not doing those other things that are healthy, like exercising, taking care of mental health, watching those other comorbidities, the diet itself won't do much. The other plug I'll give here in diet is we know that MS is an autoimmune disease, and we know other diseases, for example, celiac disease, where people have an intolerance to gluten, is also another form of an antibody or autoimmune disease. And so some of those diseases come together. And so again, if you are someone that says, I eat gluten and I feel worse, my fatigue gets worse, or I have dairy and I notice every time I have dairy, my fatigue is worse, then that is something that I would say, just because it hasn't been studied in the MS context doesn't mean that it's not relevant to you as an individual. The next question, similar to diet, is about calorie restrictions and the effect on MS. And so there has been a few really small studies looking at intermittent fasting as a version of calorie restriction. And then kind of looking at how does that do with MS. And again, kind of alluding to what I said earlier, diet studies are very tricky in MS because I think it's hard to say diet would produce enough of an effect where we would see a one-to-one correlation. My experience and the data that is available about calorie restriction or things like the ketogenic diet or things like intermittent fasting is has not been any harm detected. There are a few studies that are ongoing. So that is something that has the potential to change in terms of benefit or risk. I think, again, making sure that you are doing what feels good for your body. rather than doing something just because some website or some blog or somebody said you should, I think is a really important thing. And then the other resource, when I was kind of talking about those care teams earlier, nutritionists are an important piece of that. And so always feeling free to ask your neurologist or your primary care doctor if there's a nutritionist you can see that can help talk you through some of these diets as well. The next question about correlation between adverse childhood experiences and MS, that's a really good question. I don't know that it's actually been formally studied. So things like adverse childhood events, I know there is quite a bit more in terms of resources looking into kind of the effects that has on longer term outcomes, including health outcomes. It is interesting because we know stress or significant stressors, as most adverse childhood experiences are, have a role to play in autoimmunity, but they don't happen in isolation. And what I mean by that is in those individuals that ultimately end up developing an autoimmune disease or MS, we know there is an underlying propensity for that disease or an underlying susceptibility. And so is it possible that an adverse childhood event can be stressful enough or be enough of a stressor to precipitate that change in someone who's susceptible? I think it's possible. I just don't know that I actually have good data to quote you there. Just kind of thinking about childhood impacts in terms of development of MS, the ones that have been well established. Is things like low vitamin D levels. We know childhood obesity has a role to play because we know fat cells tend to be inflammatory. And then exposure to secondhand tobacco smoke is also a big one during childhood. The other one that we know has a correlation is the Epstein-Barr virus. And I know I've got a question about that a little bit later, which maybe I'll just do now. The question I have is, since we know Epstein-Barr virus is the cause of MS, what is recommended to reduce it and its cofactor strep? Also, what's recommended for repairing damaged neurons caused by EBV? So I might take a step back and say, I don't think we can strongly establish that EBV is a cause of MS. I think it is a factor in the development of MS. Again, if we look at kind of the prevalence of EBV or how many people develop mono as children, as adolescents, as young adults, we know we don't see a one-to-one correlation. Gosh, we see a significantly lower correlation in terms of the number of those individuals that actually go on to develop MS. And so we know there is, again, I think there is a underlying susceptibility in those individuals that then get infected with EBV, and that can serve as the trigger. So I think it's a little bit hard to put that causality there. Thinking about how do we reduce it, there are several studies looking at an Epstein-Barr virus vaccine, which I think would be really interesting. So other than just MS, when we think about the association of Epstein-Barr virus with different diseases outside of just MS, we also see that associated with lymphoma as well. So it would be interesting to see as these vaccines come out for development, if they're able to do something that would really help reduce the incidence of Epstein-Barr virus. Would we see a decrease in some of these specific lymphomas or cancers that we see, as well as MS? And I think the answer to that would be yes, but the question would be, if that's not the trigger in these individuals that are susceptible, is it possible that we might unmask other triggers? And I think it's a question that leads to several other questions that I think are real questions right now. I think the more we learn about the causes of MS, I think the more questions we have. Next question that I've got is any early predictors of MS, such as optic neuritis? Really great question. So I would say, I don't know that I would use optic neuritis as an early predictor. We know the majority of people that develop MS, the first symptom that often shows up, or the first neurologic symptom, is often optic neuritis. There is an interesting idea of something called an MS prodrome, which is this idea that for years leading up to the MS diagnosis, we see this increased utilization of healthcare resources. And what that means is We see more primary care doctors visits. We see more ER visits for kind of non-specific symptoms, symptoms that don't necessarily, we don't say, oh, you've got tingling, it must be something in the brain or spine, more non-specific things, maybe this increased fatigue and stuff like that. It becomes really hard because, as you well know, gosh, those things, those non-specific things are called non-specific for a reason, where we could say fatigue can be related to MS, it can be related to not getting great sleep, it can be related to thyroid abnormalities, nutritional abnormalities, other disease states. And so it becomes hard because some of these earlier predictors become very non-specific and challenging. I think one of the things that becomes the most important is kind of campaign awareness, or awareness of the disease of MS, and making sure that we are screening people earlier. One of the neat things, just as a complete side note, but I think something most people here will be interested in. There's several big MS conferences throughout the year. One in particular called ECTRIMS, ECTRIMS. They have a wonderful patient day program that I think is recorded on their website. So if you haven't seen it, that might be a really great resource to look at too. But one of the things that every year happens at ECTRIMS is a big update on research and the science. And I think Dr. Alvarez, my guess is probably doing a research update for the Fall Education Summit for what happened at ECTRIMS. And so one of the things that's come out of it is looking at, well, how do we diagnose patients with MS earlier? So you guys have all heard us maybe talk about these criteria for the diagnosis of MS, and the McDonald criteria is the original criteria that we've used. So as of just 2 weeks ago, when this conference was held, there's new updated diagnostic criteria for MS, making it easier for us to diagnose people sooner or catch symptoms sooner, because we know the diagnosis sooner, it can have a bigger impact later on in life. Let me see where I left off. MS and pregnancy. That's one that I think there's also probably longer videos that I'm sure Kelsey can also link, kind of talking about MS and pregnancy. It's a pretty broad topic. Overall, most MS patients do pretty well during pregnancy. One of the things that happens during pregnancy is our immune system gets less active. And if we think about that just from an evolutionary standpoint, it makes a lot of sense, because a baby is only half you, half someone else. And so you don't want your immune system to attack that, because then no one would be able to carry a pregnancy successfully. And so we kind of think about MS in general being a pretty safe time for most of our women, or pregnancy being a safe time for most of our women that have MS. And the time period that we really want to be most cognizant of is looking at that time period in the first 3 to 6 months afterwards. We actually just presented something at the ECTRIMS conference a couple weeks ago, showing that perhaps the use of disease-modifying therapies or the use of specific medicines before pregnancy can actually affect how often people relapse after pregnancy. So happy to talk about that more if there was a specific question related to MS and pregnancy. The next question I've got is how to best support a young adult with a recent MS diagnosis. And I love that someone's asking this, because this is an incredibly important question. A lot of it's seeing what they need, and I bet there's probably patients here in the audience that could probably talk your ear off in terms of what was best for them when they got diagnosed. And I think it's a little bit different for everyone. I think being educated on what it means and understanding where the facts are with MS and kind of what's fiction. And just making sure that you're kind of plugged into their mental health. We know we see a significant increase in rates of depression and anxiety in individuals diagnosed with MS. And it's not necessarily just because of the diagnosis. We know there's probably something biologically that happens to the brain that causes this propensity for increased anxiety and depression. And so making sure that you're watching out for that, because sometimes it's hard for individuals themselves to recognize that. I think that's a big piece. There's lots of support networks. And I think sometimes support networks mean more than us as doctors or you as older individuals, is what I'm presuming from that question. So there's a really great group with the Rocky Mountain MS Center called the Young Professionals Network that, Kelsey, correct me if I'm wrong, is mostly 20 and 30-year-old individuals with MS. And I think sometimes also seeing that peers are doing okay with this diagnosis, I think is also incredibly helpful. So those are kind of the resources I would think of. There's also great resources through other nonprofits like the National MS Society or the MS Alliance of America. So worth looking at all of them and just making sure you're educated. Okay. The next question I've got on here is, which drug is recommended when a person has difficulties with Ocrevus? I've had difficulties with my vision. I can no longer write my name or turn pages or open envelopes. I'm bedbound and can't even bend my legs anymore to put on pants. And gosh, that is challenging. I would say, and again, kind of going back to something I probably talked about right at the beginning, I think things that become incredibly important here is kind of the utilization of our larger care team, which I will answer the original question, I promise. But the reason I say that is we know, if we think about in general, how quickly we lose function when we age. And then if you add on MS to that, gosh, we lose that function really quick. And so kind of thinking about, can I utilize my physical therapists, particularly thinking about the legs? Can I use my occupational therapist, particularly thinking about like with the handwriting or turning pages? Those become incredibly important because the less and less we use them because of the MS, the quicker and quicker we lose the motor function of those. And so even though sometimes it feels futile or it doesn't seem to make a ton of sense for doing therapies, if you feel like you can't do something, I think they become incredibly important at slowing down that rate of loss. Going back to the original question is what medications are recommended. So another thing that's come out of this conference that's interesting that I think we'll have to see more data on, but here hopefully soon, is we had data presented about our second Bruton tyrosine kinase inhibitor. So for those of you that aren't familiar or it's been a while since you've heard about them, these are oral pills that work on the Bruton tyrosine kinase receptors, which work on signaling between different cell types. And there was a lot of excitement that this would be a really exciting medication, not only for relapsing MS, but also for progressive MS because it has penetration into your central nervous system where your brain and spine are located. So the first medication, the first one of this class, Evobrutinib, fortunately had a negative trial, meaning that it wasn't successful against the drug it was being compared to last year. And the second one, which is Tolebrutinib, was actually just announced at ECTRIMS 2 weeks ago. It's not too longer than 2 weeks ago now. And interestingly, they had a negative trial also looking at relapsing patients, which is the same situation that Evobrutinib, that earlier medication, had. But interestingly, they had positive results when they were looking at their secondary progressive patients. Now, I think there are still some really big questions to answer, which the company, because the results just got released, I don't think has had time to put together good sub-analyses kind of looking at this, the things that make us all scratch our heads a little bit in ways that I can't quite understand. Is this idea that they don't see any decrease in T2 lesions, which are the lesions we see, or the lesions that we see bright on the T2 flare sequences. But interestingly, some of these patients had an increase in T1 lesions, which are the lesions that show up bright with contrast. So the question becomes, does it activate some of these old lesions or make the blood-brain barrier a little bit leakier? And I think a lot of these are hypotheses. And I think as we get more data released from that trial looking at secondary progressive MS, I think we'll understand that a little bit better. And so I bring this up as potentially this medication might be an option. I think the biggest caveat with a medication like this is always making sure that we're paying attention to side effects. So the Bruton tyrosine kinase receptor is present throughout the body. It's not just located in the brain and spine. And so we often see a lot of liver abnormalities associated with this in the trial for this medication in particular. The drug was briefly put on hold, I think, before it was recognized that it can cause significant liver injury. In fact, one of the patients in the trial ended up having such severe liver damage that they required a liver failure, which was they unsuccessfully recovered from. So it's not necessarily benign. So I think it is one of those things where we want to make sure, especially in our patients that have significant disability, like I'm hearing in this question, want to make sure that it's one, effective, and two, also safe. The next question I've got is, what is smoldering MS? And this one is one that, again, has gotten a lot of attention because I think it's also the ad campaign for the medication that I was just discussing. So smoldering MS is this concept. It was actually described as a pathogenic term, meaning it was something that pathologists, when they were looking at lesions, MS lesions under the microscope, they would see these activated rim of what we call microglia and macrophages. And that's the idea that comes into term about this smoldering idea. You'll hear a lot of things that get interchanged with this idea of smoldering MS. The other big term that's going around right now is PIRA, which is progression independent of relapse activity. And I think Dr. Corboy might have done a talk about this recently. But that one it's this idea that we, in some diseases, so some diseases that we treat, like neuromyelitis optica spectrum disorder, there's this idea that all the disability just comes from a relapse, and in between relapses, there's no additional disability accumulation. It's just what happened with that relapse, which we know in MS, and I bet if we all had our videos on, we were raising hands, I'd probably get half of the room to say, well, my doctor told me my scans are stable, but I feel worse. And so it's this idea of, is there ongoing disease activity, ongoing progression that we see that's not necessarily associated with new lesions or lesions getting larger? The next question, are there disease-modifying medicines that are safe for someone over 65? And I would answer yes. I think a lot of it, and this one's a little bit hard for me to answer, I think a lot of it depends on individual risk tolerance and discussions with your doctors. If you're someone that's had MS since you were 20 and you haven't had any new disease activity in 20 years, gosh, would I really think that there's a huge benefit in putting someone over the age of 65 on a disease-modifying therapy? Probably not. But if you're someone like someone I saw in my clinic recently who's in their late 70s and just had a new cervical spine lesion, then do I feel like the benefits there are greater than the risk? And I think the answer to that is also yes. And so I think a lot of it depends on your individual case. Now, there are medications that we think are all the way on this end as immunosuppressants. And there's medicines that are all the way on this end where we say, hey, this has an effect on the immune system, but it's not depleting or deleting part of the immune system to the point where people are at significantly higher risk of getting infections. And I would say the medicines more over here are probably the ones that we think about being safer, because we know everyone's immune system starts to become less active during aging. Usually thinking about at the ages of 50, 55, 60, you go through these changes called immunosenescence, where your immune system gets less active. And so kind of thinking about how do we not amplify that lowered immune system activity by increasing risk of infections. And that actually segues really well into this next question that I have on my list, which is to quit disease-modifying therapies or not to quit. When the side effects are too horrible and my scans have been stable, quitting medicine feels right for me. And there it says input. Again, I would say very, very individual depending on your case. For me, as a neurologist in particular, things that have never made sense to me, again, speaking just on my end, is to put you on a medicine that makes you feel worse than the disease makes you feel. And so I think that's definitely a really good conversation with your primary neurologist. If you say, I'm taking a medicine that makes me feel terrible, the good news is if they still think you need medicines, there's lots of medicines out there. We're lucky that we're in an age of MS where we're not stuck to just one or two or three medicines. We've got lots. And so I think definitely a conversation to have with your neurologist. There's never anything that's 100%. So again, I mentioned my patient in their late 70s with a new cervical spine lesion. And so again, never anything that's 100%. But I think we can risk stratify where we can say your risk is high, your risk is moderate, your risk is low. The next question I've got, again, kind of in that same category of disease-modifying therapies. What, if any, DMT would you recommend to a 70-year-old with primary progressive MS who's taking a break from Ocrevus after 8 years because of repeated illness or infection? What about waiting for the BTKis? So the BTKis are the medicines that we just talked about. I think one of the things that becomes really interesting when we're thinking about primary progressive MS is if we go back and look at the drug trials for Ocrevus that looked at primary progressive MS, you'll see that they excluded anybody that was older. I think it was 55 in their primary progressive trial. And so if we say, okay, we're taking information that on average, most people in that trial were in their 40s and applying it to someone who's in their 70s, we're already kind of charting unknown territory because there's all of these complexities with the immune system that happen, particularly as we age and even particularly with ongoing exposure to CD20s like Ocrevus. And so I don't know that I would go out of my way to say, all right, we put you on another DMT, because I think the biggest thing is if we're putting you on a DMT, we want to put you on something that is going to be demonstrable in terms of an effect. So I will say for most of my progressive patients, and I think I've spoken with my colleagues about this, and I think most experiences are fairly similar. I would say there's about a 50-50 in terms of my progressive patients having a clear benefit in terms of either complete plateau of their progressive disease or a slower rate of decline than they were having beforehand. And I think the things to weigh there is, are we actually getting a benefit? Or are we just exposing to side effects without getting a clear benefit? And I think that's sometimes one of the things that is challenging to look at when we're thinking about that. But I don't know that I would necessarily recommend jumping straight to another DMT. Again, we kind of talked about the tolebrutinib data, and there's additional ones that are being studied in primary progressive MS that we will hear about probably next year in terms of final data. And I think if they have meaningful data that shows a clear benefit, then yeah, it makes sense. But I, again, always want to make sure that we're balancing risks and benefits.
Dr. Shah, while you're talking about Ocrevus, we did have a comment in the chat that somebody is a secondary progressive MS patient, and supposedly there's only one option, Ocrevus.
Yeah, I will say there is a lot of taking the data from the primary progressive trial and applying it to secondary progressive MS. And I don't think that's unreasonable because there's not great secondary progressive MS trials. And I think most neurologists think most MS neurologists think most of MS is on this spectrum rather than very distinct separate categories. I think a lot of it comes with interpretation of data too. So there's another medication, an oral medication called Mayzent. Its other name, its brand name or generic name is Siponimod, that's approved for secondary progressive MS, but I don't know that anyone in our center truly believes it works for secondary progressive MS. And so I would say that category of medicines that Ocrevus falls into, which is that anti-CD20s, I think is probably what most of us believe works the best of what we've got on the market for secondary progressive MS, but I don't know that I would go as far to say that it's as good of a medicine for secondary progressive MS as it is for relapsing MS, which I think it's a fantastic medicine for relapsing. I think it's an okay medicine for secondary progressive, and I think that's an area where our field needs a lot of work, and a lot of work is being done because I think our medications just aren't quite up to where we need them to be for our progressive patients, and that's for both primary progressive and secondary progressive. I think I just have one last question on this list. And if there's other questions in the chat, I'm happy to talk about those. Which is the interest in learning about Fenebrutinib, which is said to, quote, curb nearly all disease activity in relapsing MS trials. So Fenebrutinib is another Bruton tyrosine kinase inhibitor that is similar to the other two that we've talked about, but that one does have a study in primary progressive MS. And so that is something that we will get more data out about. I'm thinking probably sometime next year is my hope, at least from what I've heard. And so hopefully we'll see a little bit more. I think there's a lot of optimism behind this class of medicine in progressive MS, primarily thinking about how we get this CNS penetration, and that it affects more than just the B cells. And we know the B cells are only a piece of the picture when we're thinking about progressive MS. We know that there's lots of other cells involved, including some of those that I mentioned in smoldering MS, like the macrophages and microglia. And so the thought is really, can these medicines be more effective? And I will say we're all cautiously optimistic. And I think for those of you that are my patients have probably heard me say that. But I think a lot of it will come down to what the data actually looks like when they ultimately present it, including what it looks like in different subgroups, including those that have active MRIs, meaning contrast enhancing lesions, and those that don't.
Dr. Shah, we did have a question in the chat. Wondering if you have heard of the shoe brand Cadence specifically made for MS.
No, I haven't, although I feel like I saw a review of these online randomly because I think I look up enough MS stuff that I get some of these targeted ads. I haven't had any patients that I've specifically heard use these shoes. Give me a second, I'll look it up real quick so I can hopefully say something more intelligent about it. Than that, I'm curious, it looks like Bob is saying they have reduced his tendency to fall. Am I a victim of the placebo effect?
I
So I
also had a
think, yeah.
second comment related to the shoes, talking about potential danger for wearing them while driving. So I just wanted to throw that in as well.
Yeah, I'm curious. I'm looking at their website right now. I think I'm truly a little bit of a cynic at heart when it comes to most things advertised for patients with MS. And I think it's because there's a lot of patients with MS, and I think there's a lot of things marketed, and I don't know that I believe most of the things that are marketed. And so I'm trying to get a sense of how these are supposed to work, and I don't know that I'm finding it really quickly, other than it telling me a bunch about MS on the website. I am sorry, I don't have a better answer, but I'm not sure that I see a ton on the website. I think the things that I think work the best in general is really just making sure that you're using shoes that feel steady and comfortable. For individuals that have foot drop, shoes like this probably won't be super helpful. The thing I like the best for people that have foot drop and not necessarily just toe drop, that Terry is talking about in the chat, is the SIBO step, which is SAEBO step. It's kind of like a modified version of the ankle foot orthotic. It's just a little less bulky. I think things like that work a little bit better. I would say if this is something you wanted to try, again, not to sound too cynical, but always see what their return policies are before you get it. Other questions?
We did have one more. How does the use of antidepressants or anxiety medication look different for people with MS?
Really good question. It shouldn't really look too different. I will say there's probably specific antidepressants that I tend to maybe reach for a little bit more. And those tend to be the ones that have less of the other side effects. So the examples I'll give is a lot of antidepressants have sexual side effects. A lot of MS patients will have sexual dysfunction as part of their MS, especially if they've got thoracic spine lesions or other spinal cord lesions. So sometimes I will try to pick medications that don't necessarily augment existing symptoms. The other thing that I think is really helpful when we're kind of thinking about side effects is there's also side effects that we can use to our benefit in MS. So for example, if I've got patients that have migraines or patients that have nerve pain, there's some antidepressants or anti-anxiety medications that do that, but also have a secondary benefit in terms of migraine reduction, or reduction in neuropathic pain. So like painful pins and needles, burning, things like that. And so if we can use a medicine for more than one purpose, that's certainly something I always like to do. There is also another antidepressant. There's a couple that have more of an activating feature to them rather than a depressing feature. And so, of course, my patients that have fatigue as a big portion of their MS, sometimes we'll try to use those and see if we can utilize that activating feature a little bit as a side effect to our benefit. So it's really quite individualized, I think, per person, but I don't know that any medications are necessarily completely off the table or 100% the one that every MS patient should use, just because it's anxiety or depression related to MS.
Right, we'll do just a final call for questions. I'll give everyone a moment, and during that time, I will share. Dr. Shah has mentioned several awesome presentations. If you are on our website, you can easily search for the family planning, pregnancy, the update that Dr. Corboy did on PIRA, or progression independent of relapse activity. He also did a presentation for one of our recent Ed Summits on DMT usage over a lifetime, as well as we have extensive resources on the DISCO MS trial talking about discontinuing MS medications. So if you can search for those quickly and easily, but if you'd like, you can also email me directly and I will send you those links. My email address is just education@mscenter.org. We are also, again, having our Fall Education Summit on November 16th. Dr. Alvarez will be doing those research updates from the ECTRIMS conference with a heavy focus on the BTK results as well as the new diagnostic criteria. And I think we have one more comment about the shoes.
I'm gonna have to look into these shoes. You guys are making me curious. It would be interesting. There's a lot of MS platforms and discussion sites. That might be a good place to crowdsource for Bob, who's interested in communicating with others who have tried them, in terms of seeing kind of what other experiences are. I will say Terry's comment about, was it Terry's comment? About one of them slipping off the car brake pedal does make me a little nervous. So use with caution.
Excellent. All right. Thank you, everyone, for joining us tonight. Thank you, Dr. Shah, for your time. This video will be emailed out to everyone tomorrow and available on our YouTube. And again, I would just encourage everyone to search our YouTube for topics that you're interested in. We do these type of events. This Conversations on MS happens 8 times a year, and all of those topics are indexed, so you're able to quickly find what you're looking for. And maybe you'll find some more presentations or webinars on the topic as well. So thank you and have a wonderful evening.
Thanks, everyone.